My name is Angela Brand. I use the she, her pronouns, and I'm the director of the CARE TA Center. I'm going to get us started this morning with our fireside chat. I'm really excited to welcome Michelle Cabrera. We're going to start off by chatting about the workforce, some of the work that's currently being done around California right now in response to a report that recently came out.
My name is Michelle Cabrera, and I'm the Executive Director of the County Behavioral Health Directors Association of California. I see a few of our members on here and definitely know several of you from different meetings and venues. But for those of you who I may not have had the opportunity to connect with yet, CBHDA is a statewide advocacy organization representing the interests of our county behavioral health directors, as well as the leadership for the two city-run mental health authorities in Tri-City and Berkeley. And it's a real honor for me to be able to work on behalf of our county behavioral health safety net as an advocate on statewide issues in the legislature and with the administration. So really happy to be here today and to have this really important conversation. Yeah, I guess I'll just say it's been a really incredibly intense time for behavioral health policy and advocacy. I joined CBHDA in 2019, right before the pandemic. And at that time, the legislature was then very focused on issues such as homelessness and sort of the intersection with behavioral health. And then the pandemic hit, and we had started conversations around CalAIM prior to the pandemic. Those were put on hold. And then while we were still sort of climbing our way out of some of those pandemic related crisis issues, the state really restarted the CalAIM reform effort. And so a lot of our work has been, intense system transformation, things like payment reform, eligibility criteria, really sort of nuts and bolts core kind of issues to try and modernize and update our systems to function better so that we could be less compliance oriented and more client oriented. And yet all of that happened, sort of when we lifted pause and we sort of started to go again, we still weren't quite entirely out of the pandemic. And a lot of the intensity and the desire for change really intensified as a result of the pandemic and all of the related issues that came with that. So what I can tell you is that the last few years, the safety net for our public behavioral health system has just been undergoing so much change. I don't think I need to tell you all about it. You're living it, right? And it just keeps coming. So we are having a moment as behavioral health generally, and it's the expression or the phrase I've been using is everything everywhere all at once, to reference that movie that was so popular in the Oscars recently. It's just been a lot happening all at once. Under insurance more generally, there has been this concept of ensuring network adequacy, which is just the state or a payer will contract with a managed care entity, and they want to ensure that managed care entity has what's considered a sufficient network to meet the needs of the beneficiaries that they're contracted to serve, right? And California's managed care plans, whether they're commercial plans or Medi-Cal managed care plans, have had some core requirements around network adequacy for some time now in California. I would say California is probably one of the leaders nationally in sort of developing these laws, which are intended to protect consumers, right? And I'll just say, kind of go back one more level because I'm a health policy geek, so I can't help myself, but I'll just say, in health policy, we have a market-driven healthcare system in the United States. And that means that, there's a profit motive. There's, it's business. California's been a little bit unique in that regard, in that when managed care plans were really brought into Medicaid in the early 90s in California, we also stood up a network of publicly run plans, right, as an effort to sort of um, counter some of that profit motive within Medi-Cal. And so that's why we have things like county organized health systems or health plans and local initiative plans that are run by counties. And in behavioral health, this specialty safety net has always been really grounded in county. And even though we went from sort of a county agency kind of set of services to becoming managed care plans, right? And now having those rules put on us, we're still structured a little bit differently than other plans are. We don't get a per member per month, for example. And so how some of those rules apply to county behavioral health is really different. But yes, the state, developed brand new network adequacy rules. They've rolled them out for county behavioral health. And I'll just say those rules are different for county behavioral health plans than they are for managed care plans. So I could get into all of the weeds on that, but I'll just say some of the, the concepts around network adequacy have only been with county behavioral health plans for the last like 4 or 5 years. And I would say we're still iterating, we're still sort of developing out what does it mean to have network adequacy in a specialty public behavioral health safety net system. In managed care plan land and in private commercial coverage land, it is different again because they're not looking at as detailed a level at what their networks are like and what access is like. Those things are all measured differently. I can tell you for many people with commercial insurance and coverage, they are underserved by their commercial plans. They don't get adequate access. And so a few different things happen. Either people, if they can afford it, they go out of pocket, so they self-pay for services when they can afford that, or they end up sicker and sometimes so sick that they become disabled and then they become clients of the safety net. And or county behavioral health will augment or supplement whatever they can within their existing resources. And I know this is an area where California has really been trying to shift that, right? The Newsom administration has been really leaning into things like commercial plan parity enforcement, really wanting for both commercial plans, Medi-Cal managed care plans as well, to step up and take on more of the responsibility that they're already supposed to have, and to take some of that off of county behavioral health. However, we know that that has an impact on the workforce for county behavioral health, right? And I will say, I think overall, the number of changes that are happening, the increase in demand, awareness, and acceptance around behavioral health conditions and needs, combined with policy changes that are really well intentioned, right? Like we want to expand access to services for kids at schools. We want to make sure that more people can get access through telehealth if that's the right thing for them. We want to make sure that commercial plans are doing their job better. But all of those things create intensified or additional demand. And one of the things that we know, because we were fortunate enough to get a grant from the Kaiser Foundation of Southern California, is that the supply of qualified individuals who can deliver behavioral health services, generally speaking, is very limited. We have an older workforce. We have a workforce that is not very diverse. It doesn't reflect the populations that we're trying to serve. And the schools that are training and educating people they're not even keeping up with break even at this point. So we were able to use this funding from the Kaiser grant to study both the available supply of the workforce, plus who's working in county behavioral health now, and to really leverage some of that network adequacy data. So the the data that we're already sending to the state in order to do an analysis, which we contracted with the University of California at San Francisco, the Health Force Center there. They're the preeminent experts on healthcare workforce analysis and data. And they were able to come up with some really interesting findings.
What is the current landscape of our workforce?
I will start out with one of the aha takeaways that I got from Janet Kaufman's report that was done for us. And the first one is when we analyzed, and this is the cool thing about this report, we were able to just look at county behavioral health workforce. So again, not managed care plans, not commercial plans, not the self-pay providers, just the county behavioral health safety net. And I don't know about you all, but I was surprised to learn that 30% of our workforce in county behavioral health fall into the other qualified provider paraprofessional bucket. That was shocking to me, a third of our workforce. The next largest segment of our workforce are licensed and associate marriage and family therapists, and then licensed clinical social workers at 24% and 17% respectively. In our SUD workforce, substance use disorders workforce, the vast majority of that workforce are SUD counselors. So 68% of the workforce are SUD counselors. And one of the interesting things that Janet's report also pulls out is that, again, looking at the supply side of things, 31% of the psychiatrists in our state, now we're looking statewide, are at or near retirement age. So 31% are 65 years of age or older. That just blew my mind. We have, they are, in my opinion, they're over retirement age, right? But still working in many cases. And then 27% of our clinical and counseling psychologists and 16% of our marriage and family therapists are 65 or older. The ethnicity and the racial makeup of our workforce also, again, generally speaking, not just in county behavioral health, does not reflect the diversity of Californians. But even within county behavioral health, our workforce are largely and overwhelmingly white women. I would say, and this is one area where I think it's a positive, but the work is not done. Our workforce in county behavioral health overall does align more or less with the languages spoken by Medi-Cal beneficiaries. So that's a positive. We actually tend to recruit more Spanish-speaking workforce than our, a disproportionate number of Spanish-speaking workforce than what's available. However, on the SUD side, that's not the case. And so unfortunately, we don't have enough Spanish speakers in our SUD workforce in this public safety net in California. The other thing that Janet found is that we have a maldistribution. So where people are at also does not reflect the needs of Californians. And there are significant disparities throughout the Central Valley. I'll just say that, if we were to focus our energy and workforce in one place in the state, it would be the sort of San Joaquin Valley up and down, right? Starting with the northern San Joaquin Valley all the way down. The inland area of the state is just really, really at a deficit in terms of workforce. Racial and ethnic makeup and diversity, we've got a significant underrepresentation of both Black and Latinx behavioral health professionals. We see that API professionals are also underrepresented, with the exception of at the level of the physicians. And one more thing I just want to highlight here as far as this study goes is that we are not at a point right now where we are churning out enough graduates to meet the demand. And in fact, the number of graduates of master's degree programs in social work, for example, has actually decreased over the last several years by 4%. And the number of this is even more startling and concerning, the number of graduates from SUD counselor programs has significantly gone down by 21%. And so if you look at the sort of impacts of the pandemic on things like substance use disorders, fentanyl use, those kinds of things, like that sort of supply issue compared with how much we rely on SUD counselors in our safety net is of major concern to us.
What do you see as some of the pressing issues around recruitment and retention?
I would say when we look back on this period of time in history, the sort of accelerated pace at which services move to telehealth modalities is going to be one of the giant disruptions that came out of the pandemic, right? And one of the things that CBHDA struggled with, I would say even early days in the pandemic, was that the move to telehealth services was being presented a lot in the public space by other trade associations in healthcare as like a, a, a positive, full stop. And what we were hearing from our folks was, nah, right? Like a lot of the clients in the safety net system either could not engage through telehealth modalities because of the conditions of poverty that they were living in. So I don't have broadband or Wi-Fi or cell phone minutes. I don't have a laptop. I don't have a private place to sit and do therapy where I don't have a bunch of other people in my household listening in on my conversation, right? Like I'm homeless, like whatever it is, there were so many practical barriers that had to do just with the low income of the client population that we serve, not to mention other co-occurring disabilities, et cetera. And so there was this big conversation happening that was being driven by other parts of the healthcare sector, including people in the safety net. I would argue a lot of the, FQHCs that serve people who are in the more mild to moderate category were rah, like all about like, yes, yes, yes. And what we kept saying to state policymakers was, yes, and like, can we both lean into what is potentially useful and beneficial about telehealth, but also understand that we cannot not do in person, right? And I think from going back to my earlier comments about how we have a market-based system in the United States, right? We know that psychiatrists now are in the catbird seat where they're saying, well, I don't have to come and do work in person. And not all psychiatrists are approaching it this way. Like we have some very, committed, passionate people who know that there's value in face-to-face, who know that they got to be touching hands-on or in the field. But I would say those folks are the exception rather than the rule right now in the industry, right? And so there are certain professions like psychiatry that can command telehealth work only, or say, I don't want to come in and do this work. But the needs of the clients really are what need to matter most for us in the safety net. And I know I heard from some behavioral health directors who said, when we went to primarily remote or telehealth services, we saw that some of our clients decompensated and did worse, right? In some counties, some places, people said we saw those sort of crisis levels shoot up as a direct result of what we think was the telehealth impacts, right? And so we have been pushing for a more nuanced approach to telehealth, but also in our work around the workforce report that we did with UCSF, to really emphasize that it starts upstream. We need the schools that are educating and training people. And this came from our county behavioral health directors, from the leadership in county behavioral health. We need them to train a workforce that understands safety net populations, understands field-based work, wants to do that, has curricula and tracks that are designed around that, right? Because too many of the schools that are training the LMFTs and the psychologists, et cetera, have been more oriented towards the business side of things, right? Which is the sort of track to the self-pay kind of clinician, rather than looking at justice involved populations, forensic behavioral health, or child welfare overlay and those kinds of things. And we think that the kind of work that county behavioral health does is so meaningful. And so it could be really interesting to particularly a lot of folks who may want to serve their communities. And so there's an opportunity there for students, for colleges and universities, and also for us to really transform what the pipeline looks like and where it's headed, what it's leading into.
You talked a little bit about, all of these things that are happening right now, the change in plans and initiatives at the state level. But if you could highlight maybe some of the things that the state is looking at.
I hope nobody takes this as like, that CBHDA or our members are trying to sort of, discourage telehealth modalities. For some people, it's absolutely appropriate, right? And for some people, it's all that's there, right? And so without telehealth, we wouldn't have as much access. So telehealth is a wonderful tool, but it's not the end all be all, and it can't be it. And really, with new benefits coming online, like the mobile crisis benefit, like there are places where it's not even an option. So, we have to be thinking more dynamically here. In terms of what the state's doing, I'll just highlight a few different programs and initiatives. So the first one actually was a law that came into place in 2020. That's SB 803, which allowed California to opt into peer specialists within Medi-Cal. This benefit is just starting to come online. Again, the bill was passed in 2020, the first year of the pandemic, and we've had to stand up a whole certification process as county behavioral health and get that online as an optional benefit in Medi-Cal. So that's amazing in terms of, the long-term effect and potential behind the peer support specialist benefit. The other thing that I want to highlight is that the state really was aware and focused on the behavioral health workforce needs. Again, even going back as far as pre-pandemic, and has doubled down and redoubled those efforts. In the past couple of years, the legislature and the governor have approved 1.5 billion in workforce initiatives for the behavioral health workforce and healthcare workforce. However, the one thing I want to highlight is that despite the fact that those things were approved in the budget, there was a proposal in January of this year to delay implementation of some of those really amazing and very necessary investments. And so, for example, a lot of that funding is flowing through the Department of Healthcare Access and Information, or HCI, at the state level. And some of the really positive things that happened in the last couple of years' budgets, there was a $52 million social work initiative, a $48.5 million addiction psychiatry fellowship initiative, a $52 million behavioral health professional grant initiative under colleges and universities. There was 30 million put into Masters in Social Works, 70 million for nursing initiatives, and then 15 million for the Song Brown nursing grants. Those initiatives really help to address the behavioral health needs in our system, are proposed to be delayed currently per the January budget, along with and this is sort of tangential, but the community health workers investment also proposed to be delayed. We're going to be keeping a close eye at CBHDA on the governor's May revision, which is going to be coming out in just a month from now, to see whether the May revise continues to propose a delay of those behavioral health workforce investments, or whether those change in any way. We know that there is strong support in the legislature to carry forward with some of those investments. And I'll just say that the workforce report that we did, I think, was really well timed to demonstrate the dire need for some of those things to move forward. And because it's going to be so hard for us to pull off all of the ambitious reforms and new initiatives that the state wants in the behavioral health space if we don't have the humans to do it, right? Like at the end of the day, those things are going to be, mere ideas on a piece of paper if there aren't people to make that happen. And it's going to take time, but we got to get started sooner rather than later.
What are some of the recommendations for things that can be done right now? So, how do we, knowing that some of these things are going to take some time, as money rolls out?
So there's so much that can be done. The first thing I'll just highlight is, hopefully, if folks are working in the county behavioral health safety net and they have student loans and student debt that they're carrying, they're inquiring about opportunities for loan reimbursement because there are a variety of options, both at the federal level, but also under workforce education and training, or WET funds, that were earmarked for counties to be able to provide loan reimbursement. And that's for folks who are already in the system, right? And we just encourage folks to seek out and explore those options and opportunities. Get rid of as much of your debt as you possibly can. The other thing is, we know that counties have been doing salary studies and working to increase pay and salary where they can, looking for different ways to bump up, again, pay for individuals. So there's been a lot of discussion about that. And we hope that, we can continue to emphasize that. Now, a lot of our ability to increase pay for staff relies on how much money is available in the system overall. So I'll just tell you, we know that there's an intersection there. Workforce, support initiatives. Like, I know a lot of counties are looking at ways that they can really help to provide community and collegiality across their teams. I know for our county behavioral health directors, having community with one another is so important in helping people to kind of do the tough jobs that they do, and that is true. There's a lot of there's some things that can be gained by having support with one another. We also know that in terms of resources and supports, folks are looking at different work arrangements, alternative schedules, those kinds of things. And county behavioral health directors have been really creative in talking with one another about sharing ideas across counties about how they are supporting folks. I saw the comment too about starting earlier in trying to raise awareness about careers in the behavioral health professions. And I just want to say, we've done a lot of work to fund school-based programs and cite programs at schools. And one of the things that several counties have done, including some of the ones that I know are on this Zoom right now, is they've started to really pull some of that workforce and career awareness kind of programming into their school-based behavioral health services, so that as they're kind of doing a twofer, helping young people as early as middle and high school to understand and have awareness that, hey, there's potentially a career for you in doing public behavioral health work over the long run. Because, I know, as many of you do, a lot of times young people just don't even have awareness about what kinds of jobs are out there and what kinds of things they could do. And there have been some really creative initiatives even to use young people as peers and give them some of that early experience. A lot of earn and learn programs are available as well. And then counties have also been investing some of their funding into trying to stand up some of their own educational partnerships, whether it's with colleges and universities, really just putting our own money where our mouth is and helping to support expanding training and education possibilities in partnership with both local colleges and universities, but also other entities that do virtual. So we've been very actively participating in working to try to make investments in our own staff and building out that pipeline, while at the same time looking forward at broader statewide investments that can make a difference.
Any final reflections or, anything to leave the group here with?
I just want folks to know we are in terms of the policy recommendations piece. The Kaiser Workforce Grant included two pieces. One was an analysis of the needs, and the other piece was a strategic plan for a 10-year plan to look at what can be done to help build out the public safety net workforce. And so we're going to be in the next month or so releasing that report as well, which has many more very detailed recommendations and ideas, everything from, marketing campaigns to licensure and certification requirements. We for sure have been working on things like documentation reform to try and make working in the public behavioral health system better for people. So we'll have an opportunity for additional engagement and discussion around some of those very tangible ideas as well. I do think that doing work in the public safety net is a labor of love. People do this work because they know how meaningful it is to change people's lives in these ways. And the workforce that we have works with, some populations who have tremendous needs. And so the good news is there's a lot of attention and focus on behavioral health needs right now in this moment, right, in 2023. The bad news is there's a lot of attention and focus on behavioral health right now in 2023. And so, everybody has an opportunity, I think, right now to be a part of something really massive and big and this huge cultural shift. And, we're really looking to get creative, like I said, and think outside of the box. Like we know housing has been a barrier for people in certain parts of the state. We really want the state to kind of think creatively, not just again about, loan reimbursements are limited in that they primarily serve people who can afford to get a loan to begin with and start that career track to begin with. Like if we really want to diversify the workforce, we're going to have to get creative. We're going to have to think outside of the box. We're going to have to think to stipends and earn and learn and some of those other kinds of things. And hopefully over time, we will see as well that California will, build out its workforce so that we have diversity, not just among our peers and paraprofessionals, but up and down the leadership of our systems and across different clinical disciplines. Because in behavioral health, unlike many other kinds of services and medicine, being able to relate to the person who you're working with is so much more important. And I do think that is sort of where young people in particular are taking us, right? They, as consumers of behavioral health services, say it's not just enough for me to have access to a person. I want a person who can in some way relate to my experience. And so over time, we hope that we can really plant the seeds now and grow that workforce so that it's more appropriate for our safety net populations as well.
Thank you so much for being here with us today. So I am thrilled to introduce Juan Acosta to this space.
Well, good morning, everybody, and thank you for having me. I'm glad to be here. I'm Juan Acosta. My pronouns are he, him, his. I began my work out of my own passion and labor of love, as you all were just mentioning. I began advocacy work at age 13 at a time where I was really struggling. And it is when I first understood what mental health was. And naturally, I got involved in the peer force as soon as I graduated from college and have been working for a nonprofit for the past almost 4 years now, supporting the Warm Line and the state of California with college throughout the state and providing that peer support 24/7, 365. In addition to that, I've been able to contribute to numerous advisory boards. I'm currently on the board of directors for the Steinberg Institute. And a lot of my work really focuses on addressing and trying to support underserved communities in a more intentional way. It is something that I feel like I needed growing up. I'm 25 now, and I just really want to ensure that young people, especially other young LGBTQ plus immigrants like myself, have the support and the adequate language, the descriptions, the definitions to be able to support their mental well-being. Well, Youth Voice matters so much because we have been needing that opportunity to voice our concerns and our needs to the people creating the resources. Oftentimes, when I connect with other young people and speak with them, we all want more involvement in the field. And at times, there is many resources, but they're not intentional in really outreaching to the young people and to considering their needs. And it's something that we have struggled with for a long time, especially when we look specifically at underserved young people who may not be able to speak so openly at home about their mental well-being, who don't have that safe space and a trusting adult to speak about these things with. I believe it's also important because historically we have seen the mental health field operate as a one size fits all, and we know that it has not been working, and it's something that needs to change for many young people who are from different cultures or may belong to different communities. They're oftentimes on survival mode, and taking care of their mental health is seen as a luxury, not just by their family, but by themselves because of their own struggles, socioeconomically speaking, and with other barriers in mind as well.
In your experience and within the work that you're doing, what are some of the best ways to reach out to engage or support young people and or their families? When we're thinking about the stigma of mental health and, maybe some of those barriers to access or, barriers to care.
I think what I've seen in my work and just in my own personal life is that the biggest barrier is communication. I think when we are in the field, we assume that everybody knows what mental health is. We assume that everybody knows what depression is, what anxiety it is, and what it looks like, what it feels like. But in reality, many people don't, especially if we're like going specifically to different cultures. And I believe what works is when we speak with the families, with the parents, and help them come together with their child to understand this together. It's not really about speaking at one another, but speaking with one another to understand what's really going on. And that opens the way for people to feel more supported by their own family and by those around them to speak more openly about their mental well-being. With young people, I believe what they need more tools for descriptive language, really being able to speak to what they're feeling. I know that when I was going through a difficult time, I was confused because I knew internally I was at conflict with myself, but I did not know how to put that into words. And I think that's something that we need more of, and we need more support in schools as well, which can be controversial at times for whatever reason. But I believe that we need more preventative work and preventative measures to ensure that young people are getting that support before they reach a crisis. Young people should not have to reach a crisis point to receive support, but rather we should be providing that early on.
Maybe you could tell us a little bit about some of the work that you've done with the Born This Way Foundation, maybe some of the work that you're doing to support some change at the Steinberg Institute. Do you have a moment to share a little bit about that?
With Born This Way Foundation, I was able to contribute to just finding ways for youth to engage in a different way. Sometimes we think just direct service is what works for people, but we know that people find different coping skills that support their mental well-being, whether it's storytelling, meditation, reflection. All of these things can be tools that young people may use to support their mental well-being. So that was something that we were able to support other young people with. I spoke at the White House last year with the First Lady Jill Biden, Selena Gomez, and the Surgeon General, Dr. Vivek Murthy, at the first ever Youth Mental Health Action Forum, meant to inform the Biden senior officials administration to push more efforts for youth mental health and well-being, where we proposed ideas that would support young people throughout the nation and that would hopefully change the scape for young people to have more support in the immediate time before a crisis point. With Steinberg Institute, I've been able to brainstorm future legislation for the state of California and also revise current legislations, what has been working, what hasn't been working, and also just being more intentional when we use the words equity, inclusion. What do these things really mean, and what are we using to make sure that it is being executed efficiently? Is there like training metrics? How are we holding ourselves accountable to these things? Oftentimes, even when I do more of my LGBTQ advocacy, which ties into this as well, is we hear the word safe space. And I think oftentimes what I see is people just put up a poster that says this is a safe space, but what in fact are we doing to ensure that that space is actually safe? Because a poster isn't going to cut it for a person to trust you. I think we need more measures, we need more accountability, and we need more intentional actions that will ensure that young people feel that support.
What are some of the things that you recommend as a strategy to engage young people?
I think what we really need is to build rapport with young people, making sure that we're not just asking things from them, but being intentional in what we're asking and making sure that we are listening to them as well, not just asking to ask and not executing based on the needs. I think that's really important, but also being intentional and just outreaching. I think I'm so grateful to live in the state of California because we are so far ahead with our mental health, and yet we have a lot of room to grow as well. And what I've often seen is that counties throughout the state have all of these resources available to the people. And people don't know that there's those resources available oftentimes because we are failing in our outreach. And it's something that throughout revising legislations, throughout revising things, I often find myself back to that main point that we are not going to the people who really need these resources and explaining to them that they're there and what they are. So when we go back to one of the earlier questions that you asked, Angela, is we need to be meeting people where they're at, and we're currently not at times, and that's what's failing.
What's something that you wish someone had shared with you as you were getting started?
I think something I wish someone shared with me earlier when I was getting started in my journey was that there was space for me and that there wasn't an age requirement to be a leader or to have a voice. I think that's something that I struggle with. And as I was very jaded when I did begin this work, as mentioned, I was really struggling at that point. And having a reminder that my voice was worth something. I think I felt oftentimes going into some of these spaces uncomfortable because I was either one of the younger ones or I was trying to hide parts of myself. And now I don't care and I'm 100% myself, but it took me a while to get there. And so I really encourage those young people to gain that sense of community, connect with other young people, because there's a lot of young people who are passionate about life, who are passionate about trying to create that change. And it's not an easy thing to do advocacy. It can be really exhausting at times. It can be frustrating when things aren't going the way you want them to go. But I think what helps me is that my end goal is always to touch at least one person, whatever room I enter. And if I'm able to do that, then that's one person that we are supporting more. So I think that's really important. And I just want more young people to be involved because it is the future. It is the way that we will be able to change some of these things that haven't been working. And when I did the proclamation for Woodland that proclaimed June Pride Month for the first time, I had to speak at a public comment session in front of the city council and people opposing the proclamation. And that was scary for sure. But I think what's really helpful is just remembering the why. The purpose behind everything that you're doing is what will help you push through all of that.
Do you want to share a little bit about your experience with that proclamation?
I wanted to do something for Woodland before I moved out of that town to pursue my education at SF State. And I did not want to leave feeling like I failed my community members and like other young people like myself were going to have to go through similar things that I went through. So I emailed the city council and I asked them to proclaim June as Pride Month, and they asked for language for proclamation. I lied and said I hadn't, and I just stayed up all night researching how to do it. And I gave it to them, and we had a public comment session. I shared my story. There was people opposing, people in favor, also sharing their stories, and it passed for the first time in the town's history. So that was something that I was really grateful to contribute to.
How do we support young people who are considering work in the behavioral health field?
I began with the Warm Line right before I graduated from college, I believe. And I've been there for almost 4 years. And the work that we do is we offer that peer support for the people in the state of California. And it's something that I have seen change people's lives. I think oftentimes people need to just speak with somebody to feel like they're being supported. And that's something that I've been able to see through there. I was able to manage the program along with other assistant managers and just really be able to find things that we could be doing better. We now have a chat, we have a text uh, that we have available for people now. So I think there's so much that I have learned throughout it. And I am so grateful to have began my career in the peer workforce. And it's something that I know a lot of people have been asking for more peer workforce. And to back to what Michelle shared earlier, I think young people need to know the different career paths that they can take and what's available for them to do. And they also need to feel motivated, whether it's by having a competitive pay for the people doing this work, in addition to a work-life balance. What I oftentimes see in the field that sometimes, going back to burnout, people burn out because of the system that they are in that does not make time for their life. And I think it's unfair. And we need more young people to be educated on the different career paths, and we need a better system of just for people to work in where they're really feeling supported and not just being left to do everything themselves.
Yes, thank you, Juan. Thank you, Michelle. I super appreciate both of you being here today.